Good evening. I'm Grant Eamon. I'm one of the respiratory therapists at Belleville General. I'm going to be discussing life support tonight, primarily ventilation. I'm a little biased that way. So let's start off with a definition. What exactly is life support? It's been mentioned before, but basically it's a method of preserving or prolonging life by artificial means. There's many different forms of life support: intravenous therapy, tube feedings, and dialysis. But again, what I'm going to focus on for tonight's presentation is ventilation. So what exactly is ventilation? Well, the slide comes up. There we go. It's a method of providing gas exchange throughout the respiratory tract by artificial means. In simple terms, air is pumped into the lungs under pressure and then it's released. The device used to deliver these breaths is called a ventilator. So what's a ventilator? Fortunately, we have made a few technological advances. To start off with, the resuscitator bag. Manual ventilation can be provided by a resuscitator bag, and this is usually the first stage you go through with life support. One hand is used to seal a mask on a patient's face, and your second hand is used to squeeze the bag to deliver breaths to the patient's lungs. This isn't really practical to maintain life support for much more than 10 or 15 minutes. So how do we provide support for a longer period? With machines. And these machines have evolved over time to become more sophisticated, provide more effective ventilation, add increased sensitivity, more refined controls, servo-electronic components, microprocessor operated systems, and improved patient monitoring. So that's basically the last 50 to 60 years of ventilator advancements in 2 slides. So now you know that they're sophisticated machines and they are life support systems. So why would someone need to be placed on a ventilator? Well, there's 3 principal reasons you may wind up needing life support: oxygenation failure, ventilatory failure, and impending respiratory failure. For oxygenation failure, the person's unable to move enough oxygen from their lungs into the bloodstream. Could leave you feeling a little blue. What are the causes? Near drowning, toxic gas exposure, pulmonary edema, pneumonia, things like that. Ventilatory failure. The person's unable to adequately move enough air in and out of their lungs to clear CO2 from the blood. What can cause that? Overdose, brain injury, chest trauma, chronic lung disease, and pneumonia. There it is again. Impending respiratory failure. Some persons will develop an acute condition on top of a chronic underlying one. They're unable to cope with the additional load of breathing. Causes can be chronic obstructive pulmonary disease with pneumonia, congestive heart failure, etc. So we have 2 options to provide breathing support. We have the first choice, which would be non-invasive ventilation. In non-invasive ventilation, the breaths are provided via a face mask, and it's sealed very tightly on the patient's face. This form of support is also known as BiPAP. It's usually not practical to use for much more than a few days, and the patient still has to be trying to make an effort. If the patient's not making a breathing effort, it's far less effective. If the patient requires assisted breathing for a longer period of time, if they can't breathe on their own, if they can't maintain an airway, or they're too clinically unstable, we have to choose our second support for breathing support, which would be invasive ventilation. And these slides show our 2 current most cutting-edge critical care ventilators. So the primary difference between these 2 forms of breathing support is how the breaths are delivered to the patient. Non-invasive ventilation uses a mask. Invasive ventilation requires an artificial airway. So how do we go about doing this? Well, an artificial airway is needed to allow the ventilator to deliver air to the lungs. To put the airway in, we need some of the tools of the trade. The laryngoscope is a device that we use to expose the lower airway so we can put the endotracheal tube in, which is our actual artificial airway. The upper structures are moved. It lets us see the vocal cords and into the glottis, and then we can pass the endotracheal tube into the trachea, and this is referred to as intubation. If all goes well, you wind up intubated and ventilated. So the patient now has an artificial airway in place, and they're now on life support. So how is this life support going to be presented to the patient? How long will they need it? And more importantly, how will they get off of it? So let's address delivery. We can deliver ventilation to the patient in many different ways. These different forms are referred to as modes of ventilation. And the mode we select will depend on many factors, which include the cause of the respiratory failure, the patient's age, and any underlying conditions such as lung disease, heart disease, kidney failure, etc. The initial stages of ventilatory support, the ventilator is often set up to provide all of the breaths for the patient. The patient can still initiate breaths, but the ventilator does all of the work. As the patient's condition improves, the ventilator can be adjusted to let the patient take over more of the breathing workload. The ventilator will let the patient breathe on their own, but it will provide some assistance. And this is referred to as ventilator weaning. Once the patient has regained enough strength and the lungs are sufficiently improved, the patient can take over all of the work of breathing. At this point, the ventilator can be discontinued and the endotracheal tube can be removed. But it's not always as straightforward. In cases where there's underlying chronic conditions, the road to recovery can be very long. The more complications there are, the greater the age of the patient, the greater the severity of the acute disease process, the longer it will take to wean the life support. Ventilation can be provided through the endotracheal tube for up to 3 weeks. Patients who require ventilatory support for a longer period of time may require the insertion of a tracheostomy tube. Now, a tracheostomy is an artificial opening we make in the trachea, and this is a method that we can use in our ICU here to do this. Once you have an opening, a tracheostomy tube is inserted into the opening, and that provides a connection point for the ventilator. This becomes our new artificial airway. Once the tracheostomy is placed, ventilation can be provided indefinitely. This is referred to as chronic ventilation. Ventilation may be required for weeks, months, or in some cases, for the rest of the person's life. The decision to initiate life support must often be made very rapidly. Patients with acute conditions and minimal underlying conditions, they usually do very well and benefit greatly from these life support measures. Patients with multiple underlying chronic conditions will often have less successful outcomes. The decision to start any form of life support, particularly ventilation, should not be taken lightly, and that was alluded to in the previous conversation discussing living wills and the patient's desires. But a full discussion about whether life support should be initiated and which patients are good candidates for it will have to be a topic for another evening. Thank you.